The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.
Welcome to Spot the Bleed, an American Heart Association ICH Guideline Refresher Series, the podcast dedicated to providing comprehensive insights in hemorrhagic stroke care. I'm your host, Sue Abel, Program Consultant at the American Heart Association. We're excited to bring you content that addresses guideline-directed care across the continuum, from patient diagnosis, treatment, and all the way through secondary prevention. In each episode, you will hear from our clinical experts as they break down the ICH guidelines into tangible offerings. Thank you for joining us today as we aim to equip you with refreshed knowledge to enhance ICH care and drive positive outcomes. Let's get started.
Hello, my name is Dr. Sepideh Chagharvand. I'm one of the vascular neurology faculty at University of Wisconsin, Madison.
And hey, everyone, my name's Cassie. I'm also a vascular neurology attending at the University of Wisconsin. So today we're going to be talking about blood pressure management in patients with intracranial hemorrhage. We will start with a case, and we will use this to guide our discussion on the topic. We're going to touch on a couple of the pivotal trials that looked at blood pressure management in ICH, as well as what the guidelines recommend.
So let's get started with a case. This is a 67-year-old male with past medical history of hypertension and coronary artery disease, found unresponsive at home. On EMS arrival, the patient required a sternal rub to arouse, was unable to answer any questions or speak at all, and was not moving the right side of his body. He was taken to the nearby community hospital with a stroke code activated on arrival. Initial blood pressure was 220/104. Stat head CT was obtained on arrival and showed a large left basal ganglia hemorrhage. Patient was on low-dose aspirin for his coronary artery disease, but he was not on any anticoagulation. So generally speaking, one of the two pathways we will take here at the University of Wisconsin would be the referring provider will connect to the stroke team on the access center at our institution immediately prior to the scan being complete, or they contact the neurosurgery team after the completion of CT showing a hemorrhage in the brain.
So in this first scenario that Dr. Chagharvand mentioned, the neurologist is going to be the one giving the initial recommendations regarding blood pressure control and recommend that that provider then connect with our neurosurgeons to discuss transferring the patient for a higher level of care, ongoing monitoring and evaluation. And then in the second scenario, if the CT has already been obtained showing the bleed, they will connect with neurosurgery directly, and the neurosurgeons will be the ones giving the initial recommendations regarding blood pressure parameters. They'll be the ones arranging for transfer to a capable center, but in both situations, blood pressure management is going to be initiated locally, and then it's going to be continued en route to our hospital. So recommendations are given over the phone with regard to this initial management, including the blood pressure control. And then while all of this is happening, so drips are getting started, labetalol pushes, et cetera, and we'll go through all of that. We're also simultaneously arranging to transfer the patient to our hospital. And so today, as we mentioned, our topic is going to be how do we manage these patients with ICH in terms of blood pressure? Some of you might have listened to the recent podcast episode by Dr. Navi Sangha, and this was incredibly informative. I actually listened to it myself. He did an excellent job going through the epidemiology of ICH, as well as discussing some of the big trials that looked at blood pressure management in ICH. So we encourage you to go ahead and listen to his talk as well. I think it gives a really good background, a very detailed approach. For today, we're going to try and highlight some of the overarching themes and key takeaways regarding the management of blood pressure in the ICH patient.
So yes, we know that patients with ICH that have elevated blood pressure on presentation have a higher likelihood of disability and death. And there are several trials that have looked at the issue of the acute blood pressure lowering after ICH, and the current guidelines are based on the findings from the two largest trials that we know about, which are called INTERACT-2 and ATTACK-2. In summary, both of these trials showed no significant difference in aggressive blood pressure lowering to a systolic less than 140 compared to a higher target of less than 180. The ATTACK-2 trial also demonstrated a higher incidence of acute kidney injury in the lower target group, which was less than 140.
So in addition to some of the primary outcomes and data from these trials, I think it's really important that we take a look at the subgroup analyses too. And Dr. Sangha also mentioned some of these things in his talk, but I think they give us some useful insights regarding the timing of blood pressure control in the ICH patient. So in the ATTACK-2 trial, it showed that early blood pressure control in this subgroup analysis within 2 hours of ICH onset was associated with a lower hematoma expansion and also improved 90-day outcomes compared to blood pressure control that was achieved after this 2-hour window. In the subgroup analysis from the INTERACT-2 trial, they showed that systolic blood pressure decrease of greater than 20 millimeters of mercury within an hour and maintained for a week was associated with lower risk of disability and death. And so I think both of these highlight the importance of early blood pressure treatment in patients presenting with ICH and elevated blood pressure. Briefly, I also wanted to touch on another trial that was mentioned in the other episode, but it's the INTERACT-4 trial. So this was a Chinese study. It was published in May of 2024. And it evaluated whether antihypertensive treatment started within 2 hours after the onset of stroke symptoms would improve outcomes. So initially, they found no difference in the outcomes for all comers. But then when they went back and separated out the ICH patients, they found that they actually did better with acute blood pressure reduction in the pre-hospital setting. And this was defined as decreased risk of poor functional outcome. However, when we looked at the subgroup of patients that turned out to have ischemic stroke, the opposite was found. So they found that these patients actually had worse outcomes when they had acute blood pressure lowering kind of pre-hospital. Therefore, in general, we take from this that it's not recommended to lower the blood pressure pre-arrival to the hospital in patients that are undifferentiated. They have stroke symptoms. We don't know if it's because they have a bleed or because they actually have an acute ischemic stroke without a diagnosis confirmed or brain imaging to help guide the next steps. And so while we're talking a little bit about hemorrhagic stroke versus ischemic stroke, I just wanted to take a quick moment to contrast the blood pressure approach in these two settings. When we think about the acute ischemic stroke patient, our goal is maximizing perfusion, right? So that part of the brain is experiencing cessation of blood flow. And so we typically will allow for permissive hypertension for the first 24 to 48 hours. So less than 220 over 120. But in the ICH patient, we want to lower the blood pressure as soon as possible in order to decrease the risk of things like hematoma expansion and to improve outcomes. We have all of this really good data that tells us that this works.
So, what do the American Heart Association 2022 ICH management guidelines recommend specifically about the blood pressure lowering and management of ICH? For patients with mild to moderate ICH, that they have systolic blood pressure of 150 to 220 on presentation, the primary blood pressure target is a systolic blood pressure of 140 and maintain it in a range between 130 to 150. As we mentioned, several studies looked at the lowering blood pressure target at the lower level, less than 130, and they actually found there is an increased risk of incidence of acute kidney injury. This finding prompting the recommendation to avoid lowering blood pressure to less than 130. In addition to target the range of 130 to 150, the guidelines also specifically recommending a regimen that limits blood pressure variability and targeted smooth lowering of blood pressure to reduce hematoma expansion and improve functional outcome.
So back to our case. So this patient came in with stroke symptoms. Blood pressure was significantly elevated on arrival. And so the first thing that's going to be happening in terms of getting this blood pressure down in the absence of any bradycardia or any contraindications would be typically a labetalol push. So giving labetalol, continuing to monitor the blood pressure. If it remains elevated, they can redose in about 5 minutes. And then at the same time, usually pharmacy will be at the bedside and nursing will be assisting with getting a nicardipine drip set up, hooked up to help achieve a more sustained blood pressure control. What we want to avoid is precipitously dropping that blood pressure too quickly. So they come in with a blood pressure of 220. Ultimately, you do want to bring that down, right? But you don't want to drop them to a systolic of 110 because then that can also be dangerous. And as Dr. Chagharvand mentioned, we know that drop below that threshold, then we can start seeing some other adverse events like AKI. So then what's going to happen with this patient? So we're aiming for blood pressure control, stabilization, always going to be thinking about ABCs, right? Are they protecting their airway? We have the ED provider, who's probably the first point of contact, the neurologist, and then neurosurgeon getting involved. And so a lot of these things are happening sort of at the same time. Ultimately, this patient is going to require admission to the ICU with neurosurgery consulted or primary on the patient, depending on the situation. They're going to need some close interval imaging as well as very close monitoring of their vitals and their exam to see if there's any exam change. So during the admission, we do want to continue to lower the blood pressure. Ultimately, our goal is to get that blood pressure over time to a normal range. So usually if they come in super hypertensive, I'm going to be following the same kind of approach that I would with a hypertensive emergency type patient, lowering by about 25% in the first 24 hours, and then sort of trending those blood pressures. You don't want this patient to be getting pushes or PRNs or on a drip for the entire duration of their hospitalization. So then also thinking about what PO blood pressure medications, if the patient's able to tolerate, or through an OG tube or something like that, are going to be the best first line options for long-term management of this patient's blood pressure.
So to wrap up, based on the American Heart Association 2022 guideline, a careful titration to achieve continuous, smooth, and sustained control of blood pressure, avoid peaking and large variability in systolic blood pressure can be beneficial for functional outcome. This is a level 2A evidence, which is a pretty strong evidence. The other recommendation, which is the same level of evidence, is initiating treatment of blood pressure management within 2 hours of ICH onset and reaching the targeted systolic blood pressure in 1 hour can be beneficial in reducing hematoma expansion and improving their functional outcome. So it's better to start the drip as soon as possible, but while you are getting the drip working, you can use labetalol to drop the blood pressure, as Dr. Nankee was mentioning when she was talking about the case. But drip would be the better option just because you will have a very smooth and a control of blood pressure and you don't have a lot of variability.
Yeah, and I think that's just to kind of go off what you're saying, Dr. Chagharvand. That's a very important concept here, right? So it's not entirely about where you end up with the blood pressure, right? We know we want to lower the blood pressure, but how you get there. So if you have someone whose blood pressures are all over the chart, they're super high, then they're super low, that also portends a worse outcome. So the early blood pressure reduction, sustained blood pressure reduction, and smooth blood pressure reduction, I think, are the three big things that we need to focus on here.
Exactly. Totally agree.
Well, thanks everyone for joining us on this episode of Spot the Bleed, and be sure to check out part 2.
Thanks so much for listening today. If you would like to find out more about the AHA Hemorrhagic Stroke Initiative, please visit www.heart.org/hemorrhagic stroke. See you next time.
The recommendations and opinions presented by our guest speakers may not represent the official position of the American Heart Association. The materials are for educational purposes only and do not constitute an endorsement or instruction by the AHA. The AHA does not endorse any product or device.